Hi, my name is Celia Joseph Pauline, and I am a fourth-year medical student at the Philadelphia College of Osteopathic Medicine in Philadelphia. I am currently the Internal Affairs Co-Chair on the SNMA Board of Directors. Tonight's series is a part of the Sowing Seeds program created by our national president, Asase Obo, in collaboration with the Alumni and Multicultural Affairs National Committee. Throughout this year-long program, we will provide resources on how to succeed as a pre-med and medical student, and we'll touch on everything from financial literacy to preparing for board exams and much more. So make sure you are a national member by visiting the snma.org website and signing up to stay in the know. For tonight's series, the panelists we have for tonight are Dr. Hall, who is an anesthesiologist.
Hello.
Dr. Barrett, who's a fourth-year anesthesiology resident.
Hello.
Dr. Bradley, who's an anesthesiologist.
Hey, everybody, welcome.
Dr. Malam, who's an adult cardiothoracic anesthesiology fellow.
Hello, everyone.
And Dr. Martinez, who's an anesthesiologist resident in her third year. So we'll start the series off with hearing the personal story of our panel. So first, can you guys let us know where you trained for medical school, where you are now, and how did you choose anesthesiology as your field? We can begin with Dr. Hall.
So I'm a proud graduate of Howard University College of Medicine. I did my anesthesia residency at LSU, Louisiana State University in Shreveport. I'm currently in Houston, Texas. I am a contracted physician and I work for two major hospital systems, that being HCA as well as Memorial Hermann. I chose anesthesia because I fell in love with the operating room in medical school, and I felt that was the place where medicine really happened. If you had a broken bone, if you had cancer, if you have a broken bone, we were going to fix it. If you had cancer, we were going to cut it out. And I saw anesthesia more so as the conductor of this fine symphony that brings all of these specialties together.
Thank you. Next, we'll have Dr. Bird.
Hey, so I trained at Toro College of Osteopathic Medicine in New York. I'm currently in residency at Wake Forest Baptist Medical Center down in North Carolina. I chose anesthesia because I was always really interested in physiology, and anesthesia is really just physiology in motion. And so a really interesting aspect to be able to take care of patients from that perspective and really know their physiology and pharmacology inside and out. And that was something that really attracted me to the field. Another aspect of it that I really enjoyed was the fact that you got to do a little bit of everything. I like the fact that you can deal with an infant one day and then deal with a 99-year-old the next. So I really like that spectrum of care, and that was something that was really different, and that's what kind of attracted me to that. As far as any mentors in the field, I did have a mentor throughout medical school who was in anesthesia, but never really pushed me towards anesthesia. It was really great as far as just kind of telling me to choose your path and kind of just really take in every rotation and see where you go from there. But when I finally did decide on anesthesia, that person really continued to mentor me throughout the ending of medical school and even throughout residency, and to this day, really, at every step of the way. So that was really an important thing for me, and I'm really grateful for that aspect. And then the favorite thing that I enjoy about anesthesia is the fact that I think I touched on it before, you can do a little bit of everything. I love the fact that it's very procedure heavy. And I like the idea that you can really do anything from an infant to a geriatric patient. I really think that's really a cool feeling to have and ability to have. So that's kind of my story.
Thank you, Dr. Barrett. Next, we'll have Dr. Bradley.
Hey, everybody. I'm Dr. Stephen Bradley. I'm an anesthesiologist. Currently, I work in the United States Navy. I did one of the scholarship programs in residency. So the military paid for a couple of years to give me some bonus money. And right now I'm in Virginia at a military hospital doing fairly academic residents that I work with and teach. I'm also the host for the Black Doctors podcast. I'll throw it in there. I started that recently. So for medical school, I attended the Howard University College of Medicine, shout out to HU, where I was engaged in the SNMA chapter there. And I did have a mentor during my time at Howard, Dr. Holliday. He was an anesthesiologist on staff there, and he really took us under his wing. We did not have an anesthesia residency program at Howard, but he was influential in getting us contacts and helping us get involved with other programs, get away rotations, and write letters of recommendation. After finishing at Howard in 2014, I went to the University of Chicago Medical Center, where I did a 4-year categorical anesthesia residency program. What drew me to the field of anesthesia was initially the ICU. As a third-year medical student, I loved working in the intensive care unit on my surgical rotation and realized I didn't really like operating. One weekend, I was on call in the SICU, and I went in and scrubbed with one of the surgical critical care attendings, doing a lap chole, and I absolutely hated it. But I talked with her afterwards, and she explained to me that there's options to do critical care without doing surgery. And that's what piqued my interest. I had another buddy who was set on doing anesthesia, and he was singing his praises. So he kind of got me hooked. I made anesthesia a plan B as I went into the rest of my third year. And nothing else really stuck out to me. The ICU nature stood out the most. And that's what I ended up going into. I love the fact that I can break down patients into discrete systems and develop a tailored anesthetic plan for the healthiest of healthy patients to the sickest of the sick. You can work with pediatrics. At my current place of work, I'm credentialed down to 1 month old. And you never know what's going to come through the door when you're on call or even day-to-day. Plans change. There's a little bit of every specialty, as was mentioned earlier, in anesthesia, cardiology, pulmonology, looking up echo reports and reading those, looking up pulmonary function tests. There's endocrine. So literally a little bit of everything. I love the brief interaction that you have with patients where you actually have a finite amount of time to develop rapport and get those patients feeling comfortable with placing their lives in your hands. That's probably my favorite thing about anesthesia, being able to meet a family that may look like you, that may not look like you, that's going to hand their 2-year-old child into my arms and allow me to take them to the operating room and safely anesthetize them, wake them up, and return them with a well-controlled pain and hopefully whatever was wrong with them has been fixed. And so that's why I chose the field, and I love what I do. Love going to work every day.
Okay, thank you, Dr. Bradley. Next, we'll have Dr. Malam.
Hello, everyone. Dr. Adam Milam. First, I did a PhD in public health, and I know a lot of people have questions about doing an MPH and doing public health. So I did that first. I went to medical school at Wayne State University in Detroit, and then went to Cedars-Sinai, where I just finished about 2 weeks ago and did a categorical program. I'm currently just moved to Cleveland. I'll be starting at Cleveland Clinic in about 2 weeks for adult cardiothoracic anesthesiology. What drew me to the field was what many people have already said, just the diversity within the field as far as pathophysiology, as far as age. So get to work with the sickest patients or very healthy patients. You can work with, a newborn, or like someone else said, a 99-year-old. So the diversity in the field, the reliance on understanding physiology and pathophysiology, and being in the operating room, all drew me to anesthesia. Thank you.
Thank you, Dr. Malam. Before we'll have Dr. Martinez go, I just want to make a comment that those that are watching, you can type in the comment section for any questions that you have as we go along. We'll have a section where we'll address questions. Okay, thank you. And now, Dr. Martinez.
Hi, everyone. So I guess to start from the beginning, I was actually born in Nicaragua, and I moved to Inglewood, California when I was about 4 or 5 years old. Did my public school there. Then I ended up going to undergrad at UC San Diego. During that time, I was interested in medicine. I was a pre-med. However, I feel like I was always gung-ho about family medicine. I was all about serving my community, doing like immigration health, working with, again, underserved communities that were similar to the people that I grew up around. So I actually ended up taking 3-4 years off in between med school and undergrad, and actually took a detour to Washington, D.C., where I was accepted into a public policy fellowship program on the Hill. So I did work with the House of Representatives and many Congress members there, and just learning more about public policy, you know, how to engage students of color in the democratic process, how bills are made, et cetera. And it was a great program because it really showed me about advocacy, social justice, what our community leaders are doing, and how could we be proponents of policies that further push our communities forward. Through there, I ended up doing another detour, met a lot of great people there that got me the opportunity to work at the CDC. So I did like a national health immunization campaign. And finally, I decided, you know, it's time to go back to med school. This is like my long life dream. I don't want to say that I'm a pre-med anymore, et cetera. So I applied. I was fortunate to start at the University of Illinois in Chicago. So I did my med school training there. And again, I was still very gung-ho and passionate about family medicine. However, it was actually my sister who was also in medicine. She's actually only a year older than me, but we're both first-generation students. Nobody in our family is a college graduate. We're first to go into medicine, and we really pushed each other. And she was actually the one who like told me, she was a few years ahead of me in school, mentioned, you know, she always said that she wished she had paid a little bit more attention to anesthesia. She only did like a 1-week rotation there, and she liked it, but she was already gung-ho about internal medicine. So that's what she ended up deciding. But she told me, hey, if you like working with your hands, maybe check it out, see how you like it. So I ended up doing a rotation, and I absolutely loved it. I really enjoyed working with my hands. Like many have mentioned, the diversity within the field. Even now as a resident, I feel like I'm learning even more about how diverse it is, doing like a chronic pain rotation. You know, people usually told me, you only get to see your patients sometimes once, and they don't even remember you. However, in the clinic setting on the chronic pain side, you really see your patients for a longitudinal time. And they see you as, you know, their provider, especially more so how it relates to their pain pathology. So I was really fortunate to have my sister tell me that. So I feel like for myself, that's what I try to push for in pre-meds and students. Like, it's obviously okay to go into whatever field you're interested in, but I just want to ensure that students, you know, really look at all the different fields available. Maybe you only have like a 1-week rotation. Ask your school if they could, maybe you could do an elective rotation outside, that way you really get exposure to fields that maybe you didn't consider in the past. And unlike other schools, I think at UCLA right now, the med students, they get paired with faculty mentors. My school didn't have that, so I had to really go out of my way to look for faculty mentors. And I was, again, very fortunate. I felt like everybody in the field was just very passionate about it and was always looking forward to mentoring students. So through that, I ended up doing a sub-I here at UCLA. Again, one of my reasons that drew me to UCLA was not only that my family lived around here in Inglewood, California, but also I think our program director was incredibly amazing and nurturing, on top of the faculty, and the residents were also great to work with. So that's what drew me to our residency specifically. And again, if going later through this chat, if you guys have any questions about application process or our program specifically, more than happy to answer.
Thank you, Dr. Martinez, and thank you to all of our panelists who have provided their personal story. Next, we'll go into the question section. We have a bunch of questions from our audience. The first is from Miguel Devanish. How have cRNAs affected the field of anesthesiology? And anyone can offer their stance.
I'll tackle this one. I supervise cRNAs daily, and I also work with them in and outside of the OR. They are extensions of the physician. In some states, they do have their practice agreements where they're allowed to practice independently under circumstances, but they're still just an extension of the physician where I work in a team supervision model. I think a lot of people pose this question in worry that somehow cRNAs will replace MDs, and that's just I particularly probably the physician on the panel with the most experience in actual both private and academic practice is not a worry of mine. There's a physician shortage in anesthesia. I find that the team approach model with an MD and a nurse anesthetist is a safe practice, and that team model has been proven to be a safe practice as opposed to independent cRNA practice. So typically in a supervision type setting, it's usually a one meaning a MD to 3 to 4 cRNAs at a time. On call, it's usually a 1 MD to 2 cRNA ratio. So I know also their training has transitioned from a master's program to a doctorate of nursing program. However, I still don't see that will affect the need for us as MDs. And of course, there are certain things that nurse anesthetists cannot do. We have several panelists who are fellowship training to cardiothoracic and even critical care. That's out of the scope of practice of an advanced nurse practitioner.
Thank you, Dr. Brown. Would anyone else like to speak on that? Oh, okay. Okay, we can move to the next question. Sorry. During surgeries, what exactly are you doing? That question came from Simone Ross.
Yeah, I can talk on that. Yeah, so great question. It's something I wondered as a medical student, right? Because anesthesiologists get the rap that, we're on our phones or playing Sudoku. And some cases are more intense than others. That's kind of the beauty of anesthesiology. So depending on the complexity of the case, a lot of times some patients go to sleep. They're young and healthy. It's a routine laparoscopic cholecystectomy or some basic ortho case, and they're fine. You get to kind of relax. You're watching the monitors. The blood pressure is going off every 3 to 5 minutes. You might field a couple texts from some friends. It's poor form to be on your phone and distracted the whole case. And it's something that I avoid doing out of respect for the environment that I'm in and who I'm working with, and that perception that that's what we do anyways. Other days, you put somebody to sleep and they literally spend the whole case trying to die. Induction of anesthesia typically drops somebody's blood pressure. So you go from 120 over 80 to all of a sudden a 60 over 90 over 60. And you're treating that the whole case. You're looking at the EKG. Are there EKG changes where you need to stop the case or alert the surgeon? How much blood is the surgeon losing? Is this a patient with critical aortic stenosis that could die on induction? Is this a pediatric patient that just rolled into the emergency department with a full stomach and you have to run down there and intubate because some emergency departments don't get too much pediatric trauma or patients, and you're the person on call. During other surgeries, like Dr. Milam can speak to, cardiac surgery, the chest is open. Sometimes the patient doesn't have a heart. You're doing intra-op echocardiograms and reading the heart function and looking at that. A lot of what we do is just to keep patients safe. And it's a lot is planned before surgery. We sit down the night before or the morning of with our cases to develop a safe anesthetic plan, and then we go to the OR and execute that plan. Along the way, there are roadblocks. Maybe the patient's a difficult IV stick, and we got to navigate that obstacle. Does this patient need an arterial line? How quickly is this case to get started? Will this patient benefit from a nerve block or regional anesthesia because that'll help minimize opioids because they have sleep apnea and they're morbidly obese? So all of these things before we even put the patient to sleep, a lot of that is what anesthesia really is. And that incorporates your 4 years of medical school, that incorporates your 4 years of anesthesia training to appropriately develop a plan. And then during surgery, you execute that plan. And what I discussed was more so true for physician-only practices where you are in the room the whole time, or in residency when you are being supervised by an attending anesthesiologist the whole time. And Dr. Hall can speak to this as well. A lot of times if you're supervising, you're developing the anesthetic plan, you're evaluating the patient, making sure they're optimized for these surgeries and appropriate candidates. And then you're developing the plan and discussing it with the nurse anesthetist you're working with, or the anesthesiology assistant, or the resident physician, and helping them execute that plan. Only if you're supervising, you're executing plans in 2 rooms up to 4 rooms and making sure that all these patients are safe. So depending on how you practice, you could spend most of your days in the room or most of the day kind of running between different rooms, making sure everybody's safe.
Thank you for that. Sorry. Thank you for that. We have another question from Belfon, which is, for those who presume fellowship, what drew you to pursue a fellowship in general, and why in that field?
So I'm about to start fellowship. I'm doing cardiothoracic anesthesia. I always knew I was going to do fellowship because I want to be at an academic medical center. And for a lot of the big academic centers, you need to be fellowship trained. And so that's one of the reasons. And also I wanted extra training in cardiac. So throughout residency, I went back and forth between doing a critical care fellowship and cardiac. And critical care and cardiac have a lot of overlap, and many people are doing combined programs where you do 2 years of fellowship and get board certified in critical care and then get your echo boards for doing the cardiac fellowship. I'm only doing cardiothoracic at this time, but the patients that you get to care for by doing a cardiac fellowship, you get the sickest patients, you learn how to work with echo, and you can, like I said, just manage any type of patient. And so I wanted to be able to work with the sickest patients and be comfortable doing that. And I also wanted to be at an academic center. So those were my 2 main reasons for doing a fellowship.
Thank you, Dr. Milan.
And I think, sorry to piggyback, but also roll into a question that's coming up down the road. I don't think anybody here is a pain fellow, but along the lines of what Dr. Milan just discussed, the question about are you required to be in the OR, or can you be more clinical, especially with a chronic pain fellowship? Absolutely. Once you do that 1-year chronic pain fellowship, you have the choice to split your time between the OR and a clinic, or you can work. I have co-residents that work full-time in chronic pain in a clinic and no longer work in the operating room. You absolutely do have that option.
And I just want to add one more thing before we move on with the fellowship question. There are so many other non-traditional ways to specialize. Like, I am in clinical practice. I finished residency back in 2012, but I'm finishing the clinical pathway for my addiction medicine board. So I still can practice general anesthesia and also my addiction medicine practice, because I have a portion of my practice that's just dedicated to addiction medicine, especially now, so important in the middle of an opioid epidemic. My clinical practice counts as specialty training, where I will sit for my boards, and I'll have a second board certification, the same as someone who completed an actual addiction medicine fellowship. So I encourage anyone, not just in anesthesia, whatever you are doing, you can make it your own and tailor it to what your passion is and what you want to do as far as medicine is concerned, and as far as what you want to give back to your community.
Thank you. Okay, next question is from Maran Zaru. What are some important questions to ask residency programs, considering interviews are virtual this year and it may be hard to get a feel for a program?
I say first and foremost, as a female, ask about mentorship, ask about the ratio of female attendings in anesthesia. It's a difficult road as we are still a double minority in anesthesiology. And I know that was very, very important in my success as a resident in having a female mentor. And still to this day, there have been several operating rooms and several hospitals that I've walked into, and still I'm the first Black female anesthesiologist in that hospital. So definitely as a woman, be sure to inquire, are there full-time female attendings and staff that can provide mentorship?
I know a lot of people are worried about virtual interviews. I just want to say that at my program, we started doing virtual interviews for fellowship interviews last year, and also offering 1 to 2 people each interview day for residency virtual spots, because it was LA, it's expensive to stay, expensive to travel. And people found out the interaction was pretty good. They were able to interact with the residents, the program director, and a lot of the different attendings. So it went pretty smoothly when we streamlined that last year. But to answer that question, you want to find out where residents go after they finish residency. I think that's important to ask if they're going to jobs, if they're having a hard time finding jobs afterwards. Are they getting competitive fellowship positions? So if you know your 5-year plan and where you want to do after, that'll help tailor what residency program you go to.
I think another important thing to ask is like the relationship between the residents and the faculty. Like Dr. Hall mentioned, I think mentorship is very important, but it's unfortunate that we are minorities as females, as students of color. You aren't really going to find that much, especially in top academic programs. So sometimes I really think you just unfortunately have to put yourself out there. Regardless, I think there's always going to be people who want to mentor you. When I was in med school, my biggest advocate and mentor was a white male in his 70s. He was our past program director. And I think he really advocated for me. And I think that was important for me to see, because I felt like being trained at mostly a minority serving institution, I felt like, the only way I could feel seen and advocated for was if somebody who looks like me and who's had like the same issues in my career training, somebody who could relate, like they would be the only ones to really understand. However, it felt like, it doesn't always have to be that case. Somebody who looks like you and has gone the same route. Some people are just passionate about their field and want to encourage others to do well. On top of that, I think some of the things I also noticed is also the relationship, again, between anesthesiologists and surgeons. Like, do the surgeons respect their anesthesiologists? Are you both formulating plans together when it comes to your patient's health and surgery? I think that's very important, just because you don't want to be in a program that's the relationship is very antagonistic, where you don't feel like you're putting your part as an anesthesiologist to make sure they're coming out of that surgery as optimized as it can be. Other things was the relationship between the residents. Do they go out together? If you're young, you want to go to a city with a big program that's important for you, or you want to be in a low-key rural setting because you have a family that's growing. That's also important. Other things are how the numbers of residents affect your call burden. I came to a big program. It's almost one of the biggest, I think, in the country. So if somebody falls sick, there's always somebody to back you up. However, in smaller programs, maybe somebody else could speak to it. But I think it might be harder to take that day off, and you just feel that burden as a resident, like seeing that your co-resident has to take that burden for you when they're already very burdened with other calls. So other things to think about.
Okay. Next question is from Belfon. What are the pros and cons of having or not having ACGME accreditation in fellowship choices?
I can briefly speak to that, to the pros and cons. So ACGME accredits certain fellowships, right? There's cardiothoracic, there's pediatrics, there's pain, there's I think OB is accredited now, and acute pain is one of the newer ones, and pain fellowships, and ICU. So the benefits of some of the ones that are not accredited, such as acute pain, is that you're able to be paid more because a lot of institutions will use you as kind of a junior attending. So you may not get the full salary, but you'll get paid, double or triple of what you would as a fellow otherwise. Depending on where you want to work, if you want to work at a large academic facility, then you probably want to do an ACGME accredited fellowship, but don't limit yourself, because if you just want to develop a niche practice, like Dr. Hall mentioned, do the fellowship that works for you, that makes you happy, that gives you a skill set that you can market and find the job that you want. So it depends on what your fellowship is. If you want to do cardiac anesthesia, you darn well better do an ACGME accredited fellowship. But it really goes back to what Dr. Hall said. As you tailor your practice to what you want to do, you can tailor your fellowship to that as well.
Next question. Are you required to be in the OR, or can you be more clinical, especially with the chronic pain fellowship?
I think that's the beauty of anesthesiology. You can make it whatever you want. So if you don't want to be in the operating room, you can do chronic pain, and you do clinic. You can do procedures while you're at the clinic as an outpatient. You can also do critical care and just round in the ICU. So anesthesia is whatever you want. Like the OB attendings aren't in the operating room that much. They go for a C-section, but manage the floor and labor epidurals for the most part. So it's very flexible depending on what you want. And you can tailor your fellowship for that.
Yeah, I agree with that as well. It's really what you make of it in that sense. I know here there's a few anesthesiologists that actually work in our preoperative assessment clinic, and that's almost like an internal medicine kind of situation. A lot of those individuals have kind of on the back end of their career, so they've kind of are transitioning into retirement, but still they have that flexibility to be in a situation where you're not in the OR. So you definitely do have a lot of options to not be in the OR with anesthesia.
Thank you. Next question is, what are some tips do you have for a fourth-year medical student on an anesthesia away rotation? How do you impress the attending and fellow residents?
So actually, I did a few away rotations, and I know this year is going to be a little bit different considering what we're dealing with. But the biggest thing for me on the away rotations was just always showing an interest in whatever you were doing, always being on time, early, really, for any of the cases, and always reading up as much as you can about the cases that you're going to be doing the next day. Obviously, the amount of information, the amount of knowledge is going to be very limited as a student versus a resident. But you'll be surprised. I mean, I think there were several times where, because of how much I read up on the case, there were certain questions that was posed to the resident that I was with that they didn't know, but I actually knew about just because I read up on the case a little bit more in detail. So you'll be surprised at what stuff you can actually learn about and kind of impress your attendance on our way rotation to other fellows as well, and really not missing the opportunity to do anything as far as like a procedure that they're willing to let you do. I know that there was situations where they said, hey, do you want to try this arterial line? And I've never done one, and I say, yeah, sure, I'll try it. So I think the biggest thing is just being open to learn as much as you can, and be engaging, and really taking the opportunity to just kind of show your interest in the field on your way rotation. That's the biggest thing.
Also, I would say for fourth years doing away rotations, I did when I was interviewing, when I was a fourth year medical student, I did an anesthesia away rotation, but I also did a critical care away rotation. And I knew that that particular ICU facility, that critical care component was actually supervised by the anesthesia department, as they had fellows in critical care. And I found that environment to be not as fast paced as the operating room, where I felt I had a lot more one-on-one time with the anesthesia staff, and a lot more time to show interest and also show my knowledge base and skill set. As the patients that were in the ICU were more long-term, I had time to get to know the patients, their disease processes, which were more complicated, and ask the attending questions to show my interest, and also discussed how anesthesia played a role in a critical care setting. And like I said, it was a lot less fast paced as the OR can be, as the OR can get really, really hectic. And there are very, very sick people in the ICU, but I felt it took the stress off of me as a student to get to know my patients, study up on their disease process, ask very important questions, and develop a rapport with the anesthesia staff. So think outside of the box, because you're only, if I'm not mistaken, you're only allowed to do so many rotations in a particular specialty. So it was critical care, but it was still interaction with the anesthesia staff.
And if I can add to this, just because this is it's kind of the point of this whole thing. You guys are going to do away rotations, and you're going to want to impress people. Two things I would add: you have to be flexible. Knowing where to stand in the operating room. You can't stand between the anesthesiologist and the patient, right? Or you can, but when something happens and something becomes a little more critical and acute, you got to know to step out of the way. Otherwise, you kind of become an obstacle to patient care, and then you quickly become an annoyance. Not because we're mean people, but because we need to get to the patient quickly and continue on keeping everybody safe. Also being flexible. You'll go in with a plan that you're going to intubate, or you're going to place an IV and arterial line. Well, all of a sudden you've taken a look, and now the patient's difficult, and you need to know when the attending says to step out of the way, step out of the way. Or maybe the room's moving too slow and you don't get that chance to place the arterial line. The plans can change very quickly, and you need to be able to be flexible, accept that it's not necessarily you, it's just the fact that it is a very acute specialty that we practice in. And what I see with minority students of color, dealing with, whatever it is that we're dealing with, imposter syndrome, being overwhelmed, being in a new environment, lack of diversity. Some of the medical students I worked with as a resident and even as an attending come in very quiet. The Black and Latino students are quiet compared to their peers. And depending on who you're working with, that silence can be judged negatively. They look at that as signs that you're not sure of yourself, that you don't know the answer. When you do know the answer, you're just not as prone to speak up. So something to be aware of. Not saying to change your personality, but just be aware that silence and being meek and timid can be looked upon negatively in some circumstances.
Thank you. Okay. What should a student be doing throughout medical school to convey their interest in anesthesia to residency programs?
I think for myself, like I mentioned, I was always interested more so in family medicine. And then when I decided to make the jump into anesthesia, I sought out a mentor. And actually on my downtime during all the rotations that I had, that had more chill schedules, like pediatrics, we did a lot of clinic, family medicine, a lot of clinic, whether it was in the weekend or in the evenings or early mornings. I sought out my mentor, and I was like, hey, do you mind if I stop by the ORs, just shadow you a little bit? And honestly, sometimes when clinics for my other rotation started at 9 a.m., surgeries start very early, about 7:30 in the morning. I would go to the ORs at 6:30 in the morning. And my mentor would just let me place all the IVs on the patients that would come in the morning. And if I had to intubate, he would just let me intubate. And I think that was very amazing on his end, because he saw how proactive I was. I might have been in other rotations, but I wanted to show that I was very serious about my interest in the field. And I wanted to get to know more about it before I, took the leap and applied for residency within that field. Another thing, just wanted to echo what Dr. Hall was saying, because you are limited in the numbers of anesthesia rotations you're taking. I think one of the good advice that my mentor gave me was to just excel in whatever rotation you're doing. When I was in OB, again, I was kind of one of those students who enjoyed all the fields, and that's what also let me into anesthesia, seeing like the diversity within the field. But within OB, I loved working with our patient population, like seeing the babies born, et cetera, doing procedures on that end. And, just work really hard and show your whatever resident or your attending or the program director there that you're a team worker, because that's what they like in anesthesia, as an anesthesiologist. Like we mentioned, you work with every single field. You work with the intensivists, you work with pediatrics, geriatrics, and in chronic pain, and they want to see that you're very flexible and you're a good team player. You're able to get along and communicate well with people. So just what my mentor told me was to, you don't necessarily need like 3-4 letters of rec all from anesthesia faculty. Instead, do your best in maybe 3, all rotations. But if there's like 3 top rotations that you felt you did really well in and you put a really good impression in, ask for a letter of recommendation from those people. So like for myself, I was thankful I did well in obstetrics and internal medicine and surgery. So I got letter of recommendations from all those fields. And to my letter writers, I just let them know, hey, I really enjoyed my time during this rotation, but I just feel like I want my letters to show how, again, like that you're a team player and you work really hard, and to show how this is how I'm gonna continue doing well within the field of anesthesiology, helping, all professions overall. So I think that was important for myself and for future applicants, given this timing that you guys are applying. Another thing I think for all California, the University of California institutions, actually, they've canceled all the away rotation. So that's definitely a little bit unfortunate. But other ways you guys could reach out, every time, I think all programs, if you go to, it's either the ASA, the ASA, if you go to their Twitter, I think a lot of programs are going to start doing virtual open houses. So definitely check out that Twitter and see what programs are going to be posting about their virtual happy hours, virtual open houses, and virtual, et cetera, the application process, how it's going to entail. So I think Twitter will be sadly key in terms of staying up to date on what different programs are going to be doing during this era.
What are safe step scores to consider for anesthesiology?
I think what's important is that the field in general and medicine in general are moving away from cutoffs for step scores, MCATs, et cetera, really taking a holistic approach at evaluating the application. So a lot of programs, maybe 10 years ago had specific cutoffs. If you didn't meet this cutoff, you weren't getting an interview. But a lot of that is disappearing now. And so I think you do well on step. I think the average has been between 230s and 240s for step for our field. But like I said, that's not the only thing that they're considering right now. So if you're engaged in research, if you're in leadership roles, went to the ASA meeting, you have a mentor who's an anesthesiologist, those are really things that can help balance out your application and not just focus on the step scores.
Next question is, can you help me understand the difference between categorical versus advanced programs? How should we approach this? Should we apply to both, even though it seems better to go for categorical?
I'm biased. I did a categorical program, and I think, the vast majority of programs right now are categorical. I think the advantage of doing a categorical program is that the hospital. When you're there that intern year, I got to meet the surgery residents, the surgery attendings, medicine residents, medicine attendings, and you're going to work with them throughout your residency career. So I think it's helpful to be at the same institution all 4 years, so you don't have that big adjustment going from intern year to your CA1 year. So I only, most people only apply to advanced programs, but if you have special circumstances where you want to be in one city for a particular time, or you want to see multiple hospitals, the other programs are an option.
Yeah, I agree. I think most programs are categorical now. Mine is a categorical program. I personally applied to both. I think there are great programs out there that are advanced. I like the aspect that I went to a categorical program, but I did not rule that out as far as advanced programs to apply to. I wanted to be in a situation where I was at the same hospital for all 4 years. However, there are great programs where you have to do an intern year somewhere else and then do your CA1 to CA3 years at a different place. So I personally did not just apply to categorical programs, because like I said, there are some great advanced programs out there. I think it just depends on what you're looking for, and if you're willing to kind of move again. And actually depend on where you're doing your advanced program. If you did an advanced program, you really wouldn't have to necessarily move if it's kind of in the same city. So it just depends.
What advice do you have for undergraduates that are leaning towards a field of anesthesiology?
For undergrads, I say, focus on enjoying college, making friendships, and just being the best college student you can be. In college, you need to focus on being a successful medical school applicant, but not so much that it, destroys your life and you're miserable. Because the one thing I've learned, your own personal happiness is probably the most important thing. And you can be happy along the way. The road to medicine is tough. There's lows, there's highs. So it's a little tough, in my opinion, to set out knowing that you want to be a specialty. But it's a good goal to break that down it's a good idea to break it down into actionable steps. So the first step, obviously, is to get into medical school. If you're the high school students that reach out, I say enjoy high school and try to get into the college that sets you up to go to medical school. So break it down into baby steps and actionable items. Once you're in college, shadowing is always great. Getting on with a local hospital, becoming a phlebotomist or a scribe, if you can do that and maintain good grades. Once you get into medical school, as you can afford it as a first or second year medical student, getting additional shadowing experience and early exposure can definitely help. I did not have that opportunity. And I do wish I would have taken a little bit of more advantage of that as a first year medical student. Definitely don't spend every weekend shadowing in the OR, but every now and then, if you have a weekend off, getting some experience early on could definitely help.
What is the relationship between anesthesiologists and surgeons? Does it vary by surgery subspecialty?
I think there are always going to be stereotypes, and I think there is always going to be what some would like to say is an ongoing feud between anesthesiology and surgery. My best friends are surgeons. My mentor turned best buddy is an orthopedic surgeon, Dr. Sonia Sloan. So I don't like to feed into this stereotype because no matter what, the surgeon and the anesthesiologist, we share a patient. We both are there for our common goals of having great results from surgery. And I think when you focus on that portion of the relationship that we share in taking care of the same patient, you are going to have better outcomes. And like I said, my practice has probably spanned longer than others on the panel. I've seen a lot of changes take place in operating rooms and in hospitals. Right now, this is the first time we've ever had a surgeon general who's actually an anesthesiologist. And this, in the middle of a pandemic, our specialty has been pushed to the forefront as far as taking care of the sickest of the sick. when it comes to COVID-19. So we have to take our roles as leadership in the operating room, as well as in healthcare, public health, on national platforms. And I think that is being recognized right now. And I've worked in wonderful situations, and I have a great working relationship with the surgeons that I work with now. So I don't see this fictional feud as much as people may portray in the past. So it's an ongoing working relationship. It's hard to be an anesthesiologist and not develop a working relationship with surgeons. And if you find that to be a difficult, there are other specialties and subspecialties that you can go into. But it really is, it's an ongoing working relationship, some good, some bad. But the common goal is that you have two specialties who are dedicated to working for that patient to get the best outcome. And that's what needs to be focused on.
Do you have a, oh, sorry, I have, sorry about that. Do you have a good work-life balance? What are the shifts for that specialty?
I have an awesome work-life balance. But it took some time to get. I always tell people, like, it doesn't matter what you want to do. If you want to do surgery, if you want to do anesthesiology,
Can hear me.
Like, you can make this specialty whatever it is that you need it to be. I am a mother as well as a physician. Right now, my clinical practice is only 3 days a week, and that's by choice. That's what I chose to make it. So you can make this whatever you want it to be. I know my fellow residents on this panel may not feel like so, but the goal is for whatever you go into to make it your own, as long as you are fulfilling your life's dreams and passions.
I know a lot of choosing a specialty is balancing what you love with what you're willing to tolerate. What are things about this specialty that you wish were different?
I think it goes back to what we've been saying, is that if you don't like something about your current practice, you can move to a different practice. You can go to a different surgery center or hospital. You can change specialties even. Personally, I don't like early mornings, but it's still working out. I still love my job.
I think whatever you don't like, there's a way to change it. Even if he doesn't like early mornings, like the practice that I work with, they have a swing shift, they have a 3 to 11, they have a night shift, they have float shift. Like, you literally can make this specialty whatever you want it to be. You can go round with critical patients if you decide to do critical care and have more of a hospitalist. You can do 7 days on, you can do 7 days off. You can do locum tenens, which is like substitute teaching for physicians, and travel the world. Like, I did locums for 7 years and practiced in 7 different states, and literally made a vacation out of most of my assignments and had a very comfortable lifestyle. You can make this whatever you want it to be.
Any tips for polishing your personal statement for anesthesiology residencies?
Make it personal. A personal statement is supposed to be personal. My personal statement was more about music than anything. And the common thread, I bet on this panel, a good majority of us are also musicians. I know Dr. Bradley is. And that was like the greatest conversational piece when I was interviewing, because I wrote about my passion for not just playing music, but composing music, and how I find music soothing in the operating room. So whatever you're writing about in the personal statement, please make it personal.
I 100% agree. I think you should also send it to a couple residents or attendings to review it. But as Dr. Hall was saying, my personal statement talked a lot about public health. And surprisingly, when I went on my fellowship interviews, we didn't talk anything about anesthesiology, nothing about my experience as an anesthesia resident, but we talked everything about public health, about some mission trips that I did, the policy work that I've done in the past. And so, like she said, make it personal. Tell them about yourself. They can see everything else with your test scores and where you went to college and things like that. So put something different in your personal statement.
Okay, thank you. That was actually the last question that we can take for today's session. Thank you again to all our amazing panelists. We appreciate your support in the SNMA and our membership. For those who are watching this series right now, please scan the QR code on the screen. This will also be located in the chat. To give us some of your feedback as we work toward creating more programming for you. We also have the list of upcoming specialties in this series, so you can add that to your calendar if you have time. Okay. Thank you again for joining us. I encourage you all to follow us on Instagram at SNMA_official, on Twitter at SNMA, and like us on Facebook. But most importantly, if you are not a national member, please visit snma.org to sign up and get connected. Thanks for tuning in, and I look forward to seeing you all at our upcoming Sowing Seeds webinars.